Good morning. My name is Connie McLaughlin, and I work in the MUI unit at the Ohio Department of Developmental Disabilities. We'd like to thank you for joining us today for today's webinar on conducting unanticipated hospitalization investigations. Before we get started with the presentation, we're going to go over a few housekeeping items. All right. So this slide is a little busy. It has a lot of words on it, but I think the premise is something that we really want to talk about today, and it's how we are all part of the quality improvement process here in the state of Ohio for individuals with developmental disabilities. Whether you're a service provider, a SSA, an investigative agent, or a department staff, we all play a role in protecting the health and welfare of the people that we support. And we are so appreciative of your time today being part of this webinar and kind of having this discussion with us, because we believe it's so important to individuals' health and welfare. So we want to thank you for your dedicated service to individuals and also for being part of this conversation this morning. In terms of the GoToWebinar system itself, I believe most of you have participated in webinars in the past. But if you haven't, it's a relatively easy system to utilize. We ask that you participate by logging into your computer. You may also phone in. Sometimes it's easier to get the audio that way. If you choose to phone in as well as view on your computer, we ask that you turn your speakers on your computer down. That will alleviate any background or echoing noise. We do know that sometimes people experience some issues with sound quality, and if that's something that you're experiencing, sometimes it's easier to hang up and call back in. If you have any questions or concerns during the webinar, we ask that you call our office, and you can do that by contacting us at 614-995-3810, and someone should be able to assist you. Another part of the system is this can be an interactive conversation, and so we ask if you have questions or comments, please post those during the webinar. If we have time as we go, and we think we will go ahead and ask those questions of our presenters, and they'll be able to address them. If there are unanswered questions at the end of today's webinar, we will send them out to the group with responses from the presenters. So just know if we don't get to your questions or comments, we will make sure they get addressed. Additionally, if you have not received a copy of the handouts or the group attendance sheet, those are posted here in the system under the handouts section. And in terms of today's training, you will get 1 hour of continuing professional development credit for attending on this live webinar. And whether you need the CPDs or not, you will get a certificate. It will be emailed to the address that you registered at within 30 days of the webinar. This is something I really want to stress. If you are watching this webinar by yourself, you're logged on to the computer, you don't need to do one other thing to get credit or to get your certificate. You don't need to send in a group attendance sheet. You only would send in a group attendance sheet if, in fact, you're watching with a group. So there might be a group of SSAs or investigative agents watching this webinar together. That's when you would complete that Excel spreadsheet. You would type in the information requested, and you would email it to Roxanne Smith or me at our office, and we would ensure that your group would get the certificates. Again, if you have any questions during the webinar, you can contact our office at the number provided. Okay, so we all know that physical health impacts every other part of our life, and that's why conducting quality investigations into unanticipated hospitalizations is so important. The work that you do as a provider, as an investigative agent, and as the SSA is critical to the health and welfare of the people that we support. And it's not just about the work we do around this investigation, but what we do every day to support people to be happy and safe. And so that is pretty much why we're talking about it today. How can we focus on prevention? and enhancing the lives of the people that we support. And we believe by doing quality investigations, that's going to lead to better outcomes for people. Some of the items that we're going to talk about today are just kind of the definition of unanticipated hospitalization. That changed with the 2019 rule revision. We're going to talk about the purpose of the Category C forms, which may or may not be something that your county board utilizes. We're going to talk about the required elements of the investigations under the protocol. And we're going to talk about probably the most important things, we believe, the causing and determining factors to the hospitalization, and also effective prevention plans. We're also going to review some resources for you at the end of the presentation, and hopefully we can have some good conversation and dialogue about some of the challenges that you face and how we can support each other in doing quality investigations. So today's presenters for this topic are our regional managers, Russell Blank and Kathy Blind. Good morning to you both.
Good morning.
So I'm going to turn it over to Russell, who's going to do the next part of the presentation.
Thanks, Connie. As Connie had mentioned earlier, we're looking at, in general, a quality improvement process here. Basically, we have what starts with our initial incident, whether it be considered an unusual or major unusual incident. And then from there, what steps are we taking to further improve the lives and health and welfare of the individuals, starting with the immediate actions. How did we immediately respond to the incident? Now, going back really quick, the nice thing is whether it's considered an unusual incident or a major unusual incident, the process is still very similar nonetheless. So it's important that we identify those immediate actions and respond appropriately. From there, there's the investigation. And hopefully, as a result of the investigation, we're going to be able to clearly identify some causes and contributing factors, and then build and create some prevention and effective prevention that we're able to confirm and move forward with to help prevent any reoccurrence of this incident. What is an anticipated hospitalization? It's defined as any hospitalization or any admission or hospital stay over 24 hours that is not pre-scheduled or planned. There are two types of hospitalizations, whether it be medical or psychiatric. The MUI rule does allow that hospital admissions may be considered and prevented or not filed as an MUI if it's included in the individual service plan. Now, there are certain parameters for that, but what we would be looking for, and we'll cover a little bit more in detail further in the presentation here, but we're looking for it to be clearly stated what the condition is in the plan and how the support staff and everyone involved with the individual are to respond to that condition, and should it result in a hospitalization, what sort of follow-up is typical for that condition. Some examples here of unanticipated hospitalizations, which if you're familiar with the previous rule, were once called unscheduled hospitalizations. We now which now go by unanticipated hospitalizations. But some examples here are is listed at the bottom there. An individual has labored breathing and a rapid heart rate and is then admitted into the hospital. It's later confirmed that they were admitted with a diagnosis of pneumonia. The second one, individual has high blood pressure and was hospitalized unexpectedly due to pneumonia. That's something that perhaps I want to discuss a little bit further. Say an individual's plan recognizes that the individual has high blood pressure. Staff responds to it accordingly, takes a look, recognizes some symptoms, takes the individual's high blood pressure. It creates a concern which results in a visit to the ER. Well, the ER then admits them for pneumonia. Just because the plan recognizes it as high blood pressure, the actual admission and diagnosis is pneumonia. If that's not specified, we're going to be sure that it is recognized as an MUI and filed. Individual reports severe pain and is admitted for surgery to remove kidney stones. Looking at the categories here for medical unanticipated hospitalizations, and overall, last year, there were over 6,000 unanticipated hospitalizations. Over 5,000 of those were medical, and then just over 800 were psychiatric. If we look at the two leading categories, infection, whether it be to UTI or sepsis or whatever it may be, infection and pneumonia and flu accounted for 1/3 of the hospitalizations, which will cover flu and pneumonia. It's real important that when those occur that we're wanting to find out information as to whether or not the individual had received their flu or pneumonia vaccines. Top three categories, we have neglect, UBS, and unanticipated hospitalizations. The growing trend here is since 2016 to 2018, we went from 5,300 to almost 5,400 to 6,000. That's a little bit over a 10% increase. But again, the leading category of MUIs filed are going to be what we're discussing here today. Next, we have the Appendix C requirements. This is going to be just about everything we're looking for within the MUI investigation itself. We also have the unanticipated hospitalization MUI form available out there, and we'll discuss that here in just a moment. But some of the requirements we're looking for, whenever an incident occurs, we want to know who is reporting the incident and try and get the title of who it is and contact for that person for additional follow-up. In the report, we're looking for a list of documents reviewed. Typically, if you're reviewing these documents, we like to see it referenced throughout the report and whether or not there was significant information discovered from those documents, but clearly stated that they were reviewed and what came of that review. We look for you to go over the individual's medical history, whether it be recent similar illnesses or any known conditions. Kind of going down to the 72 hours prior might tie into recent similar illnesses. So the key thing to 72 hours prior, we're looking for what was the individual's condition or state leading up to that hospitalization. If we need to go beyond that 72 hours to see where these symptoms or say an individual's sick and showing high fever, or the fever is progressing, or their condition is getting worse, if that started beyond the 72 hours, we're going to want to go beyond the 72 hours and see where that was initially observed. Document the date and reason for the most recent prior hospitalizations. We're looking for all relevant hospitalizations and information that might pertain to this MUI. So, for example, it doesn't just have to be recent hospitalizations. If someone is hospitalized due to a fall, well, MUI review of any known injuries or falls that might have, or a UI review addressing those falls and a history thereof that can clearly state and the condition and how we might have previously responded to those incidents. Next, we have the symptoms that were addressed and whether or not it was done so in a timely manner. Again, that's also with the 72 hours prior that we're trying to see what had actually occurred leading up to it. And then we have the time frame where it's clearly identified we need to respond to this situation with whether it be transporting to the hospital and an ER visit that resulted in a hospital admission. But leading up, being sure that everything was done so in a timely manner, looking at possible neglect and being sure that we don't have a greater concern here, but nonetheless being sure that everything was followed up timely. Clearly describe the incident, what occurred. An individual was experiencing flu-like symptoms, fever, vomiting, whatever it may be, and then what led us to the elevated concern that resulted in the hospital admission. You'll also want to include the diagnosis, discharge, and follow-up summary or follow-up appointments. With this, typically, as far as the follow-up appointments, some of the incidents might be ongoing. Or some of the follow-up appointments might be ongoing. So let's say the discharge summary indicates that the individual should follow up with a neurologist, for example. Neurologist was seen on January 5th. There was a prescription, there was a medication adjustment. Both of those can be confirmed. If the neurologist requests a follow-up appointment 3 months down the road, then we would want to look at who's going to be responsible for that follow-up appointment, who's going to be responsible for verifying that occurs. Clearly identify the cause and contributing factors, and then, as I stated earlier, if it is due to flu or pneumonia, indicate whether or not the flu shot or pneumonia vaccine the individual had those. And again, verifying the prevention.
We're going to stop here for 1 second. We have a couple questions. So, Kathy, I'm going to ask you the first one. Okay, when we talk about providing recent hospital history or things like that, what would you consider recent? And I think Russ talked a little bit about this, but would you mind expanding on that a little bit?
So if they had something, maybe they had hospitalization 5 years ago, but then it was a, stop for 2 or 3 years and they started again, you can maybe go back within the year, maybe the last 2 if it's really relevant. You don't need to go back 5 and 10 years. You can certainly say, they had 15 hospitalizations between 2000 and 2012 for the same or similar, diagnosis, and then maybe there was a lapse in time, there was nothing, and maybe if you know why was there nothing? Maybe the person was no longer receiving services, and then they started up again. So just kind of think about that case specifically and what's happening, and does it kind of make sense? We don't need to go into 20 years of information unless it's really, really relevant to this case, but you don't have to go into so specific details. You can summarize that.
But you want more than just the MUI number and
Oh, yeah. Is that what you're asking? But so you might want to just say she was hospitalized. If it's say she has a history of UTIs and that's this MUI that you're covering, you can say she's had, on this is the MUI number. On this date, she was hospitalized for the UTI. This was a prevention plan for that. But you don't, just the MUI number is not going to tell us any. We're going to have to go back in and open that to see what that is. So you just want to give us a summary of what the details are.
Excellent. Okay. And Russ, a question for you is, could you address what you would like to see when you have an individual that has a history of hospitalizations, but perhaps in another county? How can the investigative agent address that?
Well, if that's the case, it would be important to reach out to, well, first of all, when that individual is coming to that particular county, it would be important that all relevant medical history, of course, is shared and reviewed with that particular county. So in the event that there's a question or concern, there's two ways you could go about that. If there's additional information that you need regarding MUI history, you can always reach out to that county and the contact of that county and see if there's any discussion regarding that individual that you can have. And of course, if there's any further questions or concerns regarding additional information, you can always reach out to whoever your regional manager is. It's really important that even though the information might be difficult to get, that we're sure to follow up and be sure that we obtain everything that is necessary to come to a final conclusion.
Excellent. So we're going to move on to the Appendix C forms now.
Yes. Now the Appendix C forms, essentially with the Unanticipated Hospitalization form, we have that available on our website, and if you're unfamiliar with that, feel free to reach out to us and we'll be able to also share that. I don't know, Connie, are we sharing this form as part of the did we share this form?
No, we did not send that. It's available on our website. We can send it out after.
Okay. But the hospitalization form is something that's really important for helping steer the investigation, let's say. It's not going to be a standalone document to basically be submitted as the final investigation, but it helps steer it. The form, again, is not the report, and on what's submitted on the form, as thorough as it is, we need to be sure that we're still following up with all the necessary supporting documents, whether it be discharge paperwork, log entries and reviews, case notes, whatever it may be, for us to be able to clearly identify the cause and then develop a prevention plan with verification from there forward.
We had a person ask a question. So one of the investigative agents just posted a question and said, you know, they utilize the form, however, it doesn't go over every single requirement within the Appendix C protocol. And so I don't know if we want to address that, and potentially we could look at revising the form. I think the form specifically just talks about that hospitalization. It certainly doesn't go in depth into that person's medical history and things
Correct.
like that. So I don't know.
So I think, again, it's an excellent tool, but it's to help perhaps direct us in the investigation. Again, since it doesn't cover everything completely, and the thing with these forms as well is the information in the forms is only as good as what's put down. So I know in the past where I've reviewed submitted unanticipated hospitalization forms. Well, back then they were unscheduled, but and not every entry had a real thorough explanation of what it was. It's really important that, especially where it's where it would be considered relevant, is, say, for example, the 72 hours. What I would often see there is no known history. Well, I would typically follow up with the provider or SSA or whoever it may be, saying, I can certainly appreciate that there was no known symptoms or conditions prior. Were there any entries into, were there any medical concerns or prior to beyond that 72 hours that might have resulted in this as well? So it's important to just not take this for face value, but again, just kind of steer where the investigation wants to go, or where you want this investigation to go based off of the information that's present on the form.
And not every county board utilizes the form, but we're certainly open to making revisions if it will make your work easier. You know, so there's no requirement to use the form again, but if you have recommendations, we can certainly revisit that and make some changes to the form to include more of the protocol requirements.
Mm-hmm. Next, I'll pass this off to Kathy.
Look out. Okay. So now we're going to do the conducting the investigation. So an incident happens, you're notified of it, and now we got to start the investigation. You're going to go in there and gather your documents, whether that's the Category C form, whether that's nurses' notes, schedules, shift notes, witness statements, anything that it might be that's going to help you to determine what happened, what caused it to happen, and how we're going to prevent it from happening again. The really important thing to remember is that if we can make sure that we're using the same diligence with a Category C as we do with an A and B, we're going to be a lot stronger in prevention. I know that if somebody in my family went to the hospital and they were hospitalized, it's a big deal. So your report should be a big deal. We should be writing it in a fashion that it's a big deal. So we're telling the story, we're getting as much information as we can. It's not simply copying and pasting the Category C form into the report, because those are just kind of bullet points. They're not a story. And we'll kind of talk about that in a little bit. But you just want to make sure that when you're doing this, we all take it seriously, I get it, but I know sometimes it's like, well, it's a Category C. Does that mean it's not that important? But it truly is. So just think about this as being your loved one, and you want whoever's ever doing that investigation to be as detailed and diligent as they possibly can. So when you start doing the investigation, after you gather the documents, you're going to interview relevant witnesses. I know that there's no requirement to do interviews, but my mom always would tell me, you know, I would text, quit texting, talk to somebody, because a text word or a written word sometimes, or words is not, it's not a story. It's not giving you dialogue. It's not really giving you texture of what's happening. So talk to that person, whether it's face-to-face or it's on the phone. Talk to somebody and just get some more details, because a lot more comes out when you interview than when you just read a written statement or a nurse's note or something. You may need to elaborate more on that. So that's really important that we consider that. And Russ already talked about not taking that Category C form as face value. We have to, if it's written in there as the IA, you have to make sure that it makes sense, what's being written, fill in the gaps kind of a thing, making sure that if there's any discrepancies in what information you gathered, that you're explaining that in the report. You can say, well, maybe this particular document said this, but the witness said that, and then you're explaining that. It looks like you're really analyzing the information and not just trying to rush through and get something on paper and on the ITS. Okay, so challenges. Now, I know I was an IA for many years, and there's challenges. We don't always get the medical records. You don't have somebody cooperating, whether it be a provider or family. Maybe I get the documentation. I have no clue what the heck those words mean, so I'd be calling somebody, hey, what is, this word, and what does it mean? So it's absolutely appropriate and expected that we're going to do that. What kind of challenges, if you guys want to go ahead and start maybe jotting down some suggestions, what challenges you're facing. If you're having a hard time getting the medical records, we really want to try to find out why. Some counties are better than others. Maybe some hospitals are better than others. And if we can really evaluate why we're having difficulty getting those records in a timely manner, then it's going to be a lot easier for you to close the case quickly, and then we can, more importantly, make sure that person that had that illness or hospitalization is getting the help they need quicker. We don't want you waiting, months to try to get a document. Do the best that you can. If you cannot, after a certain period of time, and then just write your report based on the evidence that you have, and explain in the report why you don't have what maybe you don't have a discharge note paper or something like that. Explain why, your effort that you made, and why you can't get it. Okay. Okay, so here we are. We've went in, gathered documents. We've done our interviews. We've collected everything we possibly can. And now we got to figure out, we know what happened. We got to figure out why. What caused it to happen? What contributed to the incident? We want to not repeat what happened. We want to know why it happened. So look for root causes. And I know that in a lot of trainings that we've had, we talked about asking why 5 times. So this person was hospitalized with a UTI. Well, why? Well, she has a history of, well, why? Well, maybe because she's has a catheter. Well, why? So we kind of keep going down the list and ask why 5 times. If we can get to that root cause, it's really going to help that person to maybe, or have the team maybe be able to get a better prevention plan for them. Try not to think solely on historics, but why did it happen today? Why did it happen this time? What was different? Maybe especially in those other previous case I was talking about, where maybe they were hospitalized many years and then there was 2 or 3 years with nothing, and then all of a sudden it's starting again. Well, we really want to know why. So that's a big question. Something's changed, and we want to try to figure that out. Some things to consider when you are doing these investigations is if you have a diagnosis of pneumonia, and I'll be the first to admit this, years ago, I really didn't care necessarily in my brain if it was aspiration or not. Pneumonia. Let's get this case done. Okay, sorry, Connie. But that was, the thought. So as I, learned more about it, is it aspiration pneumonia, or is it just regular pneumonia or non-aspiration? Because that's going to drive the prevention plan. If it's aspiration, and we'll cover that here, I'm not sure if it's the next slide or not, but it's going to be a big deal. And so if I'm trying to do a prevention plan for regular pneumonia and not identify with aspiration, that maybe she choked on something or drank something and got, that's not going to be a complete prevention plan.
To kind of add to that, and that's why it's important to review all relevant documentation. I can remember one of my earlier cases reviewing a discharge summary from a hospital where the individual was diagnosed with having pneumonia. There was no mention of possible aspiration pneumonia or anything, but they were discharged based off of pneumonia. Well, they had an immediate follow-up with their primary care the following day, or 2 days later, within a very recent window. And that primary care physician had mentioned in their notes that it was likely due to aspiration pneumonia. So all of a sudden, I have two different medical documents that one, though initially reviewed, indicated pneumonia. Now we have an additional follow-up now that would change as a result of the primary care physician's belief that it was due to aspiration pneumonia, which would now possibly steer a swallowing eval or whatever it may be. But it's important to pay attention to the fine details of all of those medical records.
Okay. And then finally, when you're doing your investigation, you also have to, another thing to consider is, was there any delay in the care or treatment that contributed to the hospitalization? So we always want to make sure that if there was something in the plan, or we were supposed to do something and didn't, or we, and that kind of made it worse for that person, we really, as the investigator, have to identify that and address it in the plan, so that way we can address it in the contributing factor and then also ultimately fix it in the prevention plan. All right, prevention. So when you do the prevention, it's important that we are preventing the incident from happening, not just fixing it already that it happened. Like, for example, if somebody got a cut, the discharge summary may be, well, they got staples, come back in 7 to 10 days to get them removed, et cetera, et cetera. But that's just fixing the injury. It's not fixing how they got injured. So if I get a cut, I'll make it a Band-Aid, right? That's going to help heal that cut, but it's not driving how did I get cut and how can I prevent it from getting cut again. So when you do your prevention, we don't just want to rely on the discharge paperwork, because that's just what to do after it's happened. It's not telling you what to do to avoid it from happening again. So just make sure you're focusing on that. Look at the contributing factors. If there's 3 things that you've identified as contributing factors, that prevention plan addresses those 3 things as well. If there was a previous hospitalization, please make sure the prevention plan was followed. And then also, in the event that the prevention plan that's provided, maybe the team has said they're going to be trained, a staff's going to be trained, or we're going to have more monitoring or medical follow-up, you as the investigator need to make sure it's done. So when you go to put this report on ITS, it's the prevention plan is a past tense document. It's not, I'm going to be doing this, or staff is going to be, because we have to verify. Now, you guys close these cases and we just monitor them monthly, sporadically. So we don't know until, so you have to make sure that when you're doing it, don't close that case out unless you have verified the prevention is completed, not in the process, unless it's like, if it's every 6 months she's going to be following up. Clearly, we're not going to have you keep it open that long. But if it's a staff training, just like with category A and B, you get a lot of, sometimes we send out questions like, please verify the prevention has been completed or the staff has been trained. It's the same level of scrutiny here for the category C's as well.
And I think that's a good point you brought up, because sometimes we get the question from when we're out doing accreditation reviews or other types of reviews, when we start asking questions, or you may be aware that we do closed case samplings. So for all the cases that the county boards are able to close without our review, we do a sampling of those every month, and many times those include unanticipated hospitalizations. So if you've already closed a case and you're getting a question on a hospitalization from a regional manager, that's why. And oftentimes it is about prevention plan verification, like Kathy said. It's, we'll see things that this staff will be trained, but what we need to know is this staff person was trained on this date, and that's how we verify the prevention plan has been met and implemented.
One thing before we go to the next slide, we talked about the prevention really quickly. Make sure the prevention makes sense. Let's say you certainly don't, let's say you have somebody who is not able to ambulate, they're on a ventilator, and they go into the hospital with some upper respiratory. And sometimes the hospital gives very generic instructions. It might say, to avoid chest discomfort, make sure you don't smoke, make sure you walk X amount of, steps a day. But if this particular individual that has this problem and they were in the hospital, and let's say they're 4 on a trach and in bed because they can't walk, you certainly don't want to put that prevention plan in that report, because it certainly doesn't make sense. So read what you have and make sure it makes sense. All right, now report writing. You've got everything done. You've done all your investigation. You've gathered all your documents. You talked to who you needed to talk to. Teams come together with a good prevention plan. So now you got to write the report. So again, going back to that Category C form, that is not a report. That is bullets of information. You have to make it make sense. Tell it like a story. So think about how you like somebody to give you information, or if you're reading a book, how there's a beginning, middle, and end. So it should be the same way. Just like you guys do a great job on the A's and B's, and we want the C's to be just as great. So we want to start at the beginning, talk about the person. So sometimes I see, when I'm reviewing some cases, I might see, I'm with Russ, 34. He's got a diagnosis of bum, 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 and they're listed. And this is a past MUI. And that's all I know about Russ. That doesn't really tell me about Russ. If Russ has a UTI, maybe because he cannot, or he's got pneumonia because he can't, part of he's older, maybe he can't walk around, maybe his roommate had pneumonia too. I mean, I'm going to start telling more of a story about Russ if I think of it like writing, like telling a story. So just talk about that person. We got to get to know them. We don't know them. You know them. So when we're reading your reports on ITS, that is the standalone document. That ITS report is all we have. We don't know, Russ. We don't know what's happened unless you tell us, and you tell us in a fashion that kind of flows and makes sense. Does that make sense? Okay. The report should not only include what happened, but again, why it happened, going back to the CCFs. So when you write that MUI report, you want to make sure that you're including relevant past history. Let's say you have somebody that passes away, and then you knew it was coming because they're on hospice. But if that report, let's say before you get to the death, right? When we say he's got another chest pain issue, he's in the hospital again. If that's the only paper that we have in front of us, you should explain that, 10 years ago, he was diagnosed with congestive heart failure. And then throughout the 10 years, this was the steps that happened. These were the hospitalizations that happened to him. These were decisions made that he wanted to not have any more treatment. So it kind of makes sense. It's kind of a cohesive series of events and timeline. It makes it a lot easier for who's ever reading that only paper that we're looking at. It tells the entire story. Okay. Make sure you look at any trends and address those in the report as well. Okay. So this is an example just randomly put together of what an unanticipated hospitalization would be for UTI. So you can read along. In 9/7, Mary was sent to the hospital and later admitted with a UTI. During the course of the investigation, we realized that she was given antibiotics. In the discharge summary, it says she was given antibiotics to treat the UTI. The investigation uncovered that she has a history of them, 7 for the last, for UHs for the last, 7 for UTIs. She does wear Depends for incontinence and oftentimes refuses or forgets to drink fluids. She's diagnosed with depression, ODD, and dementia. 72 hours prior, she was only drinking 6 to 8 ounces of fluid a day. It was engaging in aggressive behaviors and refusals when asked and prompted to change her Depends or perform hygiene. So based upon that limited information and contributing factors of why she got the UTI, I'm not really talking here about she's had a history of it, right? But why did it happen this time? Well, this time she's really reduced her consumption of fluids. She's not wanting to be hydrated anyway. She doesn't want to have her Depends. And so she's had more contact with her skin for long periods of time. And she's also engaging in some memory recall issues. She wants to stay in bed, doesn't want to do anything. So these are and you've noticed I listed them as 1, 2, 3. So by listing 1, 2, 3 as an investigator, I'm trying to tell the team these are 3 very important things and not one big paragraph, because it's easy to miss information if you write it in a paragraph form. Now, there's no requirement for you to do it like this, but this is a really good idea because it helps prompt and helps you to know that the team has addressed your 3 contributing factors. So now we go to the prevention plan, and we're going to go back and forth for a minute. So number 1 contributing factor was that she was only consuming 6 to 8 fluids a day. So my prevention plan for number 1 is going to be Mary and her team agreed to implement a fluid chart with reminders to help her and set goals for how much to drink. See how that correlates? And number 2 contributing factor was she refused to change her soil Depends, contributing to her having skin contact for long periods of time. The prevention plan that matches number 2 is that she had a follow-up visit with her care physician on 9/12, and she and her team were given education material on the importance of it. You know, keeping clean clothes and hygiene. And since the appointment, Mary has been very diligent in changing as soon as she's soiled. Okay, so this has given me a really good example of what's happening. Number 3 contributing factor, she engaged in memory recall issues. She wanted to kind of stay in bed, wasn't engaging in anything. She was then seen by her psychiatrist on the 14th. Due to the changes, her doctor increased her Zoloft for depression and her dementia medication. Mary has noted she's feeling more active and alert. So that's telling a really good story. I mean, briefly, but anyway, it's an idea. So when you get to, sorry, Russ is showing me the time. I guess I'm a long
good grief.
I'm teasing you. All right. So unanticipated hospitalization for aspiration versus non. So, you know, I quoted Mayo Clinic, aspiration pneumonia occurs when there's an intake of or inhale of food, drink, or vomit or saliva into the lungs. It's more likely if it's something disturbs their normal gag reflexes, as opposed to non-aspiration pneumonia, which is more of like something gets in their lungs. Air sacs may fill with fluid or pus. I'm sorry, I jumped ahead because I'm getting nervous now.
Okay.
I'm sorry I interrupted you, Kathy.
Okay, so the aspiration contributing factors would be, so let's say that maybe because something could have got caught either by drinking or eating, was the diet followed? Maybe that's a potential contributing factor. Was staff trained? Was the meal program followed? So a possible prevention plan would be maybe do a swallow study, determine if their diet needs to be upgraded or not, and then verify that the training is complete. So in this particular example, it's noted the ISP was updated and the staff were trained with the new order as of 9/14, and the IA verifies it's complete.
So just to clarify, the team is the one developing the prevention plan, but it should be based on the cause contributing factors that were identified by the investigative agent.
Yep. Okay, so this non-aspiration, possible contributing factors may be with an environmental, with their mobility issues. Maybe somebody got pneumonia because they sit and they need to be repositioned or something, where other people ill in their home. There could be a bunch more, but these are just some quick examples. Possible prevention, maybe staff was retrained on environmental safety precautions, and IA has verified the staff were retrained as of 9/14. Maybe her mobility issues, maybe they put a chart in for rotation so that all staff are aware that she needs to be repositioned, or if the person had pneumonia, that's her roommate, maybe there was a different protocol. So find out what the contributing factors are, make sure that's addressed in the prevention plan, the team addresses each one of those, and then we want to look at why it happened today, and then what we're going to do to avoid it from happening again, not just fix, the cut, so to speak.
I think it's important to note that these are quality investigations, but are not extremely long, but get to the information at hand.
Correct.
So kind of to reiterate with what Kathy was talking about with the verification that the prevention plan is something that the team comes up with based off of the cause and contributing factors. So what I know when, for example, if I'm reviewing a case file, let's say, what I'd really like to see is that there's some sort of correspondence between the IA and the team that clearly states those identified cause and contributing factors from the investigation, and then what the team had actually come up with to prevention-wise. But moving on to addressing hospitalizations in the plans, as stated earlier, that the hospitalizations themselves, there may be those incidents or those individuals who may have conditions that may result in an occasional hospitalization or a number of hospitalizations. And some of those can be identified in the plan. It's important that we aren't including incidents that would be as a result of choking or falls. Those are areas where we really want to be sure that we prevent those in general and have a clear documentation of when they occur. So when just to review this slide, a hospital admission associated with a planned treatment or pre-existing condition that is specified in the individual plan, indicating it's important to indicate the specific symptoms and the criteria which requires the hospitalization. Clearly stated in the plan. We have some examples on the following slides, and we'll kind of break those down. In this particular case, we have Jane, who's diagnosed with a seizure disorder. Jane has medication to address the seizures. Even with medication, Jane averages about 8 to 9 grand mal seizures each month. So right there, it's clearly stating what Jane has and what she receives medication-wise. But then next is, it indicates the signs of what to recognize for staff. So signs of seizure activity for Jane include the list there. DSP will need to ensure Jane's safety during these times. And then it also says how to respond. So the team is to respond if a seizure is lasting more than 5 minutes. It'll require diastat, and then leading to the, of course, diastat by a certified DSP, and then 911 to be called. If Jane is hospitalized based off of those steps there, and it's identified in the plan that it may not be an MUI. It's important to review that everything was followed. Again, ruling out neglect, taking a look and being sure that that there are no concerns or additional follow-up that may need to be done for staff regarding education, or clearly stating, having additional information in the plan itself, so everyone is best prepared to respond.
We had a question about this, Russ. So, as you know, many of the individuals that we support have multiple diagnoses. Many of them have multiple medical conditions ongoing. And the question is, if a person if it just says in their plan, like Kathy has seizure disorder, this, and lists like maybe 10 diagnoses, is that considered covered in their plan and therefore a MUI would not be filed?
No, and in fact, there was an example we were going to have Kathy. I think Kathy, maybe now's a good time to go over the example of what we would try and want to avoid. But again, with those situations, what we're really looking for is each diagnosis, how to respond to the diagnosis, and when it may result in a hospitalization.
Yeah, so basically what you want to look at to say, can I put this in the plan or not? We want to try to identify a specific illness. Do they have a history? Can we go in the ITS and see maybe this person has 15 UTIs, and it's going to likely continue because of whatever maybe they have some medical issues or something, you know what I mean? It's not like anybody's doing anything wrong kind of a thing. But we should make a specific illness with the corresponding symptoms for that illness, and then what the staff or the steps that we're going to take. So we don't really want to put everything under the kitchen sink in there. We, just if you say, well, we're going to put in pneumonia because he's old, and then we're looking in there, he's never had a hospitalization for pneumonia. That's not going to qualify for that. So there's got to be a history of it. We're going to talk specifically about the illness and what those symptoms are, so that person reading the plan specifically knows what they're looking for. And again, like Russ said, we never want to put choking in there. Anything that's going to kill somebody necessarily, like maybe I would be cautious of maybe bowel obstructions. I mean, I know some people have done that, but it's very specific what they're writing. You can always talk to your regional manager to get a little bit more detail if you come up with something. But
right, and it's also required that an incident report be written every time someone goes and is hospitalized, even if it is addressed in their plan. And the importance for that is the tracking and the follow-up and everything else. So even though you may have some additional tracking, and this is all about obviously medical coordination and prevention, we still need to have an incident report. And
the incident report itself is still an unusual incident, which then would prompt identifying the cause to the hospitalization, excuse me, and then prevention and follow-up as a result thereof. Another example in this particular case is an individual by the name of Jimmy who was admitted to the hospital for psychiatric purposes due to schizophrenia 7 times. Because there's that documented history, it's outlined in his plan how to manage best support the individual regarding this condition. And then at the last part there, if Jimmy is displaying these symptoms, his psychiatrist will be notified to discuss treatment and options, including his hospitalization. So everything building up to that is clearly outlined in the ISP individual service plan, and how to respond and best support both during and after the incident itself. Now, I kind of call this the sort of the communication with healthcare providers. We're going over this rather quickly. I think we're kind of coming to the end here, but this is extremely important, because this is preventing before we even have hospitalization. It's important that we have clear communication with our healthcare providers, who's attending the visits with the individual, and accompanying the individual, whether it be at a standard doctor's visit or the hospital, and who's communicating with the medical professionals. So I know if we have some providers on the line here, that staffing can be difficult sometimes, and sometimes we have people scheduled who are very familiar with an individual's medical history and plan to attend an appointment with that particular individual, and then there might be a staffing change. Well, if someone else is now going to attend with that medical appointment, or is at the hospital with that person, do they fully understand and can communicate? Are they prepared to be able to provide all the information? And understanding that questions might arise. Is there someone who's available that staff person can contact should they have any questions? Because quite frankly, I know every time I go to the doctor regarding myself, questions are asked of me that I was not expecting, and all of a sudden have me going in my own memory bank to answer. So who might they be able to ask and follow up?
Okay, so as an investigator, you're thinking, well, why do I need to know all that stuff? I mean, it's not, I have no control who does what. You need to know it and identify that in your investigation, because you can drive that prevention. You can say that's a contributing factor because, so and so didn't know these things. So it's a quick scenario. A 62-year-old person that fell. Nobody tells the doctor that she fell. There was no neuro checks done. The next day there's more problems. She goes to see her doctor, but again, no one talks about the fall. Anyway, so ultimately, 4 days later, she wakes up with a black eye, had difficulty breathing, and she was diagnosed with a brain bleed and died 6 days after the fall. So communicate. Make sure people know what's happening. And then here's a couple more examples as far as, somebody a staff taking an individual. They didn't know about the latex allergy, and that was a problem for the individual, or maybe they didn't know they had a drug allergy. So we want to make sure we identify if there's problems in our investigation so that we can get a good prevention.
And basically, we want to make sure, obviously, that the best person is there communicating on behalf of the individual if they need that type of support. But also, just handing someone a notebook with someone's medical information is not the best way to communicate that. Rarely does any hospital personnel have the time or the inclination to read through a binder. And I know, just taking my own family member to a hospital, even though they've been to that hospital multiple times, they have all their medical history, they're still going to ask the person accompanying that person. And so it's important that that person feel comfortable and knowledgeable about the individual they're there to support. And like Russ said, if they don't have all the answers, that's okay. But they need to have someone that they can contact to make sure that that information is available, so that the healthcare professionals can make the best, most informed decisions when it comes to that person's health care. Other things we can do to make sure that people are well supported in their health is take every opportunity to communicate with team members what's going on. If there's risk associated with unusual incidents or MUIs, those should be addressed in the person's service plan. That doesn't mean that we have to say Russ had 6 MUIs this year, but if Russ has a history of falling, we need to address those risks in his plan, and how are we going to go about supporting him that makes sense for him. We want to make sure if there's concerns or questions, that the team is coming together. The IA is not part of the team. That question was asked earlier. The IA, the investigative agent, is an objective third party who's completing an investigation and supposed to be gathering the information, conducting interviews in the investigation to identify the causing determining factors. It's the team that develops the prevention plan. And although the investigative agent is an integral part of this health and welfare process and this quality improvement process, they are not part of the team. And so we just wanted to address that because that was a question that came up earlier. In terms of, just focusing on preventative health care, if you've been in the field for any length of time, like I think we all have, and if you've ever taken someone to a doctor's appointment, I know when I've taken people to physicals, sometimes we get rushed in and out the door like they just don't want to take the time to get to know that individual, or maybe that individual is experiencing some challenging behaviors, and that makes it difficult for the office staff there. I would suggest, and many providers already do this, have some comfort items on hand for the individual when they go to the hospital or doctor's office, whether that's a game, a fidget spinner, or something, a preferred item, a book, coloring, to keep them occupied, but also don't leave until you get the care that that person deserves. You guys are advocates. You do this every day, and it's so important that the individuals that we support get the most quality health care, and that we can work together to prevent them from going back to the hospital in many of the cases. So do whatever you can do to promote healthy lifestyles and make sure they get good preventative health care. We've included some resources here, but before we end today's webinar, we have a few minutes left, and we want to go over some questions. So I'm just going to fire these off to Russ and Kathy, and you guys could address some of these questions, and then we'll get you out of here on time. So one of the questions was, an investigative agent posted that they understand that the form does not take the place of an investigation, but is it acceptable for providers to use that form as their formal investigative report? And so I'm assuming maybe they're talking about it in ICF or in terms. And so really ODH, the regulations, for ICFs, I think would prevail there. And that form may not contain all the required elements.
If it does, and that's the thing, is there still has to be a review of what's being submitted by the ICF to the investigator. So if you have all of the information and records and everything following up to that incident, and it provides all expected information and criteria that for ITS, the importance is that all areas we discussed today is able to be clearly identified and answered. So I would say take that as a case-by-case situation where we are conducting a review of the investigation and satisfied with what is being reported.
So it's not any different than like a law enforcement report. We can't dictate what they're doing, right? But we can take the report and then make it to fit what our requirements are, what our criteria are. So.
The next question is in ITS, or the Incident Tracking System. It asks if that person had recent similar illnesses, and they want that defined. How do you define recent? Is it 1 month, 72 hours, 1 year? I think we were just saying it's relevant to that person. Relevant information, yeah. To kind of really quick go off of what Kathy kind of explained earlier, is if someone had a series of pneumonia hospital admissions for a several month period, and then all of a sudden we haven't had that for 5 years, but we look back and see that, and then they're being hospitalized again for pneumonia several years later, that information is relevant even though it's 3 years later and there was a series and known. How did we follow up and how it might be relate to the current
And as far,
hospital
yeah,
admission.
as far as the ITS piece goes, you're clicking a box, yes or no. Your report's going to explain it, right? So that's more, the ITS yes or no question is going to be more for tracking purposes on our end. You're not ever going to have to worry about that. Just answer the best that you think. But make sure it's identified in the report, because that's really where the nuts and bolts are going to be, where you can explain it.
Right. And our final question is, if the hospitalization is a direct admit to the hospital, so I'm anticipating that, is that still a UI? They do not go to the ER or urgent care. So, and I think we answer this in our frequently asked questions. So if you go to your doctor and they're like, you need to go to the hospital, and that's not a planned thing, that's considered a unanticipated hospitalization. However, if your doctor says, you know, we've been evaluating or monitoring your blood work, and we feel like you need to be hospitalized for this condition or for upcoming surgery, that would not be an MUI because it's planned, whatever. But if it's just, hey, the doctor called this morning and I need to go to the hospital right now, and that's not a planned thing, it's not something that we've kind of been addressing and monitoring, then that would be filed as an MUI. But always call your regional manager if you have questions, because, you know, sometimes one fact here or there can kind of change. Also, you can utilize the frequently asked questions document and the interpretive guidelines, which are posted on the website for any additional questions. Any last minute comments from our presenters, Kathy and Russ?
Thank you all for everything that you guys are doing, supporting individuals out there, and thank you for listening.
Thank you.
All right. This is going to conclude our webinar. Like I said, you'll get your certificate within 30 days. If you have group attendance sheets, please email those to us at our office. We can't thank you enough for your dedicated service to individuals and the work that you do every day to keep them happy and safe. So thank you, and have a great weekend.